When we look at CheckMate-9LA, this trial did include both squamous and non-squamous histology. It's important to look at those ratios. About 30% of patients were squamous, which is a bit higher than some of the other studies. And we know from multiple randomized trials, including some cross-trial comparisons, that our outcomes in the squamous histology are a bit worse. And so factoring in those numbers, the outcomes are really impressive. When we break it down by histology, we did see a consistent benefit, a survival benefit in both the squamous and non-squamous histologies with fairly comparable outcomes and comparable improvements. And so this is a regimen where histology will dictate which chemotherapy you deliver with those first two cycles, but the overall approach, giving two cycles, a limited course of histology-specific chemotherapy with dual checkpoint blockade, should really apply across histologies.
It's natural for us to compare between trials. The CheckMate-227 trial and the CheckMate-9LA trial were for all histologies, whereas the other randomized trials in this setting, for instance, Keynote 189, Keynote 407, Empower 150, Empower 130, were histology specific. So we have data for chemo IO in non-squamous lung cancer, chemo IO in squamous cell lung cancer. And what we tend to see is that overall survival tends to be better in the non-squamous setting compared to the squamous setting. So we need to keep in mind that for CheckMate 227 and 9LA, what we see is a composite. So we tend to see that if we look at histology-based outcome for like 227 and 9LA, that we see better survivals in the non-squamous group. So in the CheckMate 227 study, the Nivo-Ipi had a median survival of over 19 months for the non-squamous group. And in CheckMate 9LA, survival was over 17 months. So a little bit better outcome for the non-squamous compared to the squamous. We shouldn't be carefully comparing the different trials because they're not exactly in the same population or in the same countries. Slightly different eligibility criteria, but it's only natural that when we're choosing treatment for patients, we're trying to get the most effective treatment. But I think it is useful for the different studies to make sure you're looking at the outcome for the specific histologies, because I think that can be helpful in guiding appropriate choice of treatment.
The CheckMate-9LA regimen, giving 2 cycles of histology-specific chemotherapy with dual checkpoint blockade, is another option. And we really have to tailor the treatment options to the specific patients we see. In someone with aggressive disease, a high burden of disease, that initial use of chemotherapy is appealing to really prevent that early dropping off, that early progressive events when you think you may only have one opportunity to really deliver treatment for those patients. I think including cytotoxic chemotherapy is of value. But it's an interesting strategy, really limiting chemotherapy to those first 2 cycles. By preventing continued chemotherapy, will we avoid more cumulative toxicity? Will we enable perhaps more development of memory T cells by preventing the potentially detrimental effect of cytotoxic chemotherapy over time? When we're adding chemotherapy, the dual checkpoint blockade, there will be a cost. There is certainly more toxicity when we're adding treatments to it. The rates of grade 3-4 adverse events and the discontinuation rates were higher, certainly with the 9LA regimen compared to chemotherapy alone. But some of the toxicity rates were better. The rates of anemia, neutropenia, a bit lower with the 9LA regimen, I think reflecting less cumulative toxicity from chemotherapy, perhaps less long-term neuropathy. So it has to be for the right patient, the right clinical circumstance. I think there will be a role for it. Defining a specific role for all patients is a little challenging. And so in the right clinical context, I think it certainly can provide value. The true measure for all these regimens will really be long-term survival and which approach leads to more durable survival at landmark rates, but we simply don't have those data yet.
So I think that will make a big impact. I think that many patients want to avoid chemotherapy when they can, or minimize the exposure to chemotherapy. I think that this will give clinicians an option where the patient has a significant tumor volume and they're a little bit symptomatic from their cancer, and the clinician is concerned that if the initial treatment doesn't control the cancer, that the patient will get into trouble and then won't be able to get additional treatment. So by having that option of giving the 2 cycles of chemotherapy first with the immune therapy to make sure there isn't early progression, but then having the double immune therapy on board to try to get a high level of durable immune therapy responses, that the clinician can feel confident that they're minimizing the likelihood that the cancer is going to progress early, but then maximizing the chance that they'll get a durable immune response to therapy. So I think this will help clinicians to have an option where they're really trying to avoid or minimize toxicity from chemotherapy, maximize response to immune therapy, and be able to do it safely and effectively. I think another thing I'll just point out is that when we initially had the results of CheckMate-227, we had anticipated that the best outcome might be in the PD-L1 positive lung cancers, which is evidenced by the fact that that was the primary endpoint of the study. But then we found that actually perhaps the most promising result was in the PD-L1 negative population, where it really looked, compared to chemotherapy, that there was really a marked benefit. And CheckMate-9LA, I think, confirmed that, because when you look at the outcome for the experimental therapy in the PD-L1 negative lung cancer population, it really does look quite positive and promising, and really kind of confirms the result in the PD-L1 negative patients from CheckMate-227, at least in my mind, when I kind of look and say, okay, are these in agreement, or was the CheckMate-227 result just an outlier? To me, the 9LA regimen results kind of confirm that and make me feel more confident about that result. Personally, and as an institution, we have a lot of experience with that combination. So we were involved with the phase 1 study, CheckMate-12, that went back to 2013 and 2014. So we have put a lot of patients on this treatment over many years. I think that we've really learned how to use this regimen. And I think with the low dose ipilimumab, 1 mg per kg every 6 weeks, that it really is very different. The regimen that was used in melanoma, where you might give 3 mg per kg of ipilimumab every 3 weeks. So I think even in the lung cancer population, we feel very confident using this kind of therapy. I have extensive experience using this regimen on patients in their 70s. And I've had a significant number of those patients receive a full 2 years of treatment and come off therapy because they finished those 2 years rather than they developed any substantial toxicity.